So to begin, there are a couple of really unique acronyms associated with shoulder dislocation, and it's probably beneficial for you to know these now. I don't know if Bill talked to you about these in maybe anatomy or kinesiology, but they probably cropped up, and you may know some of the associated terms. But the first one is AMBRI, A-M-B-R-I, and that is in your notes there. And that is an acronym that is associated with an atraumatic dislocation. So let me just kind of flesh that out for you. When we say there's atraumatic dislocations, these are folks who have really awesome party tricks. Meaning, like, they can pretty much walk in the door and dislocate a shoulder. And there's a really clear way to identify these kind of folks. Everybody, if you would, just take and flex your wrist for me real quick here. And then take your thumb, and can you take and push your thumb and touch your wrist? I see one. Oh, Monica, do you have yours? Everybody look at Monica, because she's kind of the corner. Monica's kind of gross. She's got this really, unique instability. And actually, I have to confess, I already cheated, and I knew Monica was probably going to land this mark. And I knew that because I saw her in the lab, and she held her arm out like this. Monica, would you do that? And everybody take a look at that elbow. And so I knew that Monica had a little bit of hyper mobility. Now, has anybody ever said, Monica, are you double jointed? Mm-hmm. Yeah. No, she doesn't have 4 knees, right? She has 2. So it's not that term has to go away. We've talked about that. I know Bill has a really, he's got a complex about a lot of things, but that word really irks him. So, and this is being recorded, I better not say such things. But, right, so you can't say double jointed, you say hypermobility. I knew that, I saw that just a moment ago, so I was kind of plotting your So, that kind of indicates to us that these people with hypermobile joints can dislocate without trauma. Now, what are we saying then? We're saying that the bone is displaced in the joint. So, think about this. You've got a glenoid and you've got a humerus, and what happens here is that humerus can come out, right? And come out and sit. There's a really cool thing that happens when we see this a lot, is right here on the back of the humerus, they can develop kind of this chronic compression fracture, a dent, if you will, on the back of the humerus. That is known as a Hill-Sachs lesion. And I don't know if that's something that you really have to look into a lot. It is talked about a little bit in the text, if you want to look that up. Hill, Hill-SACHS, Hill-Sachs lesion. And it's just basically a little compression fracture that can develop from the multiple dislocations. Now, most of the time, a Hill-Sachs lesion is associated with a traumatic dislocation. So let's look at that one real quick. Traumatic, meaning that there was some type of trauma, usually involving some rotation. So I'm thinking about like in sports where someone gets their arm kind of bent back. You see this a lot in maybe a sport like football. The quarterback is going to throw back and they get hit here, and it continues that external rotation. And what happens is that external rotation just kind of pulls that humeral head right out and then lands it on the glenoid rim. So that's more of what we think of with trauma. I myself, I dislocated a shoulder one time in the weight room, Ryan, and I wanted to tell you this story because I know that you work out with Noah, and so I don't know what kind of workout partner Noah is, but I had a workout partner one time, and he was like the most cut fit guy in the gym, and he asked me if I wanted to work out shoulders with him, and here I am, a really like out of shape, did not belong kind of guy. And he asked me, he said, I'm going to work out shoulders in the morning. You should come and work out. And I was like really honored. So I made sure I was there. And so being in the sense that it was such a big deal to be there, I was really trying to show out, way above my league, had no business doing this. And it just so happens that a young lady who I fancied very well walked in the door, and he noticed her before I did. And he stopped paying attention to my spot in the military press, which I was way overdoing. Way overdoing. I won't tell you how much because it's embarrassing. It is still low, but it was way over more than what I should have been doing. And he stopped spotting me, and he kind of turned his attention to this young lady, whom I fancied too. And all of a sudden, like in front of the lady that I fancied, this young lady, and the most fit guy in the gym, my arm went backwards. And like, I can only imagine that it like completely rotated around. And I screamed. Oh. And he screamed. And she screamed. And there was another guy down there and he was like, you need to go to the hospital. I'm like, you think? Right? Because my shoulder's now like out. This was also in a time in my life where I went home and I told my parents, who were still in bed because it was early in the morning, and they were like, we'll deal with this later. Like, that was my parents. So I don't know what your parents would do about your dislocated shoulder, but mine said, we're going to deal with this later. We're going to sleep right now. So, great childhood growing up. Anyways, back to this traumatic dislocation. So look on page 578, and it talks about traumatic hypermobility, and that's really what you're going to take care of most of the time. These atraumatics, though, they show up, they'll be there, and we'll talk about them here in just a second, but traumatic anterior dislocation is most frequently occurs when there is a posterior directed force to the arm while the humerus is in a position of elevation, external rotation, and horizontal abduction. Now, all that being said, it basically means this. People mostly anterior dislocate, meaning this right here goes on the anterior side. That's what an anterior dislocation is. There's also one called a posterior dislocation, and that's just the opposite. The anterior surface of the humerus is now on the posterior surface of the glenoid. That's a posterior dislocation. Is everybody good with that terminology? And so we can have either one of those. Now, it's associated with an acronym as well, and that's TUBS. And that means traumatic. The U is unidirectional, meaning it goes out one way or another. It doesn't have like these multiple directions, and we're going to see that in the atraumatic population here in just a minute. But it means that it goes out either anterior or posterior. It's just pretty common that it's going to go out that way. And then you get this letter B, and that B is very specific, and that is to the surgery that they're going to perform called a Bankart repair. And then the S is specifically surgery. Ambry, this atraumatic one, these are people who can walk around and they really don't have to do much. Their shoulders can just pop, like they can literally wake up in the morning sometimes and their shoulder be dislocated. Like that's just how sensitive this person is. They don't have trauma though, like from football or a car accident that initially dislocated their shoulder. Their shoulders just can pop out, right? So we understand that hypermobility. The M there is for multi-directional. So it could go out the front, it could go out the back. Gosh, it could even have an inferior dislocation, like just slip out downward. So these people are really hypermobile. Another letter there is another B. This B, though, stands for bilateral. Now, it's really important that you catch this. This B means bilateral, meaning both shoulders. So it could be both. For me, I have an instability in my left shoulder, and that's it. And really, I've been able to stabilize it enough with cuff training that it's not an issue anymore. The R says it responds to rehab. Rehabilitation. But when they do need surgery, and this comes up, sometimes they get surgery, they do an inferior capsular shift, and I'm going to tell you what that is here in just a minute. All right, so that's our ambry and our tubs. Now, let's think about this for a minute. We talked about a shoulder dislocation test, a special test that we see with these folks in seminar, and I showed you by taking my patient and we had them supine, and then we put them into this position right here, and basically what I did was I held my hand right here, but I continued to externally rotate at the same time, and that's called a apprehension test. And what they're doing is we're putting them into a position where they could anterior rotate or dislocate, sorry. But by applying that overpressure, it helps them to not have apprehension about it. But basically what happens is when I take them and I force this motion, they'll start to arch their back because they're trying to keep that from happening, right? That's apprehension, and that's why they call it that. But if you see that test performed, that's what we're looking at. The reverse is true. A posterior dislocation right here, right? So we're forcing that motion. But then again, if they're sitting on this end right here, in a supine position, they're pretty comfortable. But if you have them do that in sitting, they may do this to try to accommodate or apprehension. The book talks about something called a closed reduction. I just want to make sure that you're clear on these words. Closed reduction. So let's pretend our friend Dakari has a dislocated shoulder, right? He shows up with a dislocated shoulder. Basically, his humerus is sitting in the front. He has what's known as a sulcus sign. And let me just real quick bring you over here. Unique for cold
The Bachelor is back. Streaming live on ABC.
See, you can stream it tonight. You don't even have to worry about it.
There's a certain strain of bacteria called lactobacillus reuteri
Oh,
that will help you grow bigger balls. It was just
That was not supposed to.
R and I. R responds to that, and I is inferior capsular shift.
Alright, there's your dislocated shoulder. And it's hard to kind of appreciate this. And I'm going to turn this down because I don't know what this guy's about. Okay, so time out right there. You can really see this. You see this kind of divot right there? Alright, that word, or that deformity is called a sulcus. And that's another test, S-U-L-C-U-S. That's another test that you'll see sometimes in the special test venue, is we can take and do an inferior distraction on a shoulder, and if you get this big, large sulcus, it indicates instability. So if you see that big kind of vacuum, basically is what that is from the joint space, that's called a sulcus. But we do that in kind of a dynamic way where we grab a flexed elbow and do an inferior distraction, and you can create that sulcus. And so you can do that here in my left shoulder, but I just don't like to do it, so we're going to move on. Alright, so this guy is about to get his shoulder reduced, and it's hard, but take a look. You can see the deltoid head right there, how it's all distracted downward, right? Okay, so I don't know, he may say a series of bad words here in a moment, so we're just gonna kind of limit what he can say.
Did they not get medication for this?
Well, I was looking, actually, yeah, he's got an IV in. You know, I don't know if that's necessarily been delivered yet or not. Okay, so here's what you're gonna see. they're doing a little bit of prep work, right? With a little betadine. I don't know if you guys have you guys seen betadine used clinically? Okay, so it's a, let's see what it says here, the doctor. Young guy.
1% lidocaine.
There's your lidocaine. What does lidocaine do?
So we're spraying right below the acromion.
Whatever you
Alright, so look at what he's using. He's using a crowd freeze to numb the skin, and then he's gonna inject it with lidocaine.
It take about 2.5 centimeters or so, aspirate, and then inject the lidocaine. Big poke here, okay?
Oh.
Oh.
Yeah, it's just thought of the needle, man. That's all. That's on my own part. You know what I'm saying? My mom was junkie, man.
Environmental services at 8:15, environmental services at 8:15.
Lidocaine is for pain. It will numb, like, any type of outpatient procedure, they will probably do a lidocaine use. They also do is, when you get an injection into a joint, like, for instance, you've probably heard people say, I had my knee injected, or I had my shoulder injected. Most of the time, that comes with a little bit of lidocaine. Lidocaine is used for pain, not inflammation, just pain. And we use that in, okay, hang on.
Put some pressure down here with this hand, and I'm gonna slowly move your shoulder out towards the knee, okay? First, I'm gonna lie flat down on the bed, okay? Now, if anything hurts you, you start feeling any kind of resistance, you gotta let it down, I'm gonna stop and just wait right there for a little bit. And then we're gonna, for it to get you, the tendons to relax a little bit, the muscles to relax, and then we'll go a little bit farther, okay?
This is called the external rotation method.
Alright, here we go, ready? We're gonna put a little pressure here. Just take
So
a
they
deep breath.
Go ahead and take the arm in closer to his chest then. You gotta take it back in closer to his chest. Go ahead.
Tell me if you're alright, okay?
So distraction and external rotation.
Try not to fight it, okay? Try to relax.
I'm trying.
Try not to push.
Yeah.
Now that biceps is probably really resisting this from happening.
Okay, we can stop there, okay?
I just wrench it. Do it. Go on, man.
Take a deep breath. Just breathe.
He's massaging that biceps because it's probably really tight at the origin. Think about the tendons passing over. It's pretty subtle for you to see it, but
Oh gosh.
did you hear it? I kept the volume down because I couldn't remember if he said a swear word or not.
Oh, that looks right.
That looks right.
And don't move your shoulder too much here, okay?
Now, what they would have done, just so you kind of have some perspective on this, they would have x-rayed that first, make sure there wasn't a fracture, then put it back in and x-ray it again to make sure they didn't fracture it, put it back in. And if they did, oh well, it just happens. That's a closed reduction, right? That's what they would do there. And so when you see that word closed reduction, that's all that is. So you kind of can see that there's a lot to that, but
No, go that slow.
I'm gonna brag a little bit. I'll put a handful of those back in, and I never do that long. Of course, mine have always been on the field in football. That's the only time I've ever done that. And honestly, it happened as part of the evaluation. I just was feeling around, and I couldn't quite feel, and so I would take that and do a little external rotation, and pow, went right back in. But put the timeline on it, like literally that's within 30 to 45 seconds of injury. That guy's probably been in the ER for hours. I mean, like, think back to my story. Like, my parents were like, we'll deal with that later. And I'm like, no. And then, like, by the time they finally wake up, and I'm like, hey, can I bum an insurance card? And I make it to the ER. I mean, you talk hours go down the line. Think about all those muscles going through spasm. That's really the bad part. I mean, every shoulder I've ever put back in on a football player, it's been like that. I literally, like, I'm in there feeling around, and I just go, yeah, and it just rolls right back in. And that's just from what I've seen a lot of doctors do. I mean, the physicians that I worked with, they just go after it as quick as they can. I watched a dislocated ankle one time go in a reduction, and this was during a football practice where the doctor was on the sideline for some reason. I don't know, he was just there. Guy jumps up, comes down, dislocates his ankle. We go over there, and I mean, it's within 30 seconds. He goes, oh yeah, hold him down. Puts the guy back in. If you watch a dislocated ankle go back in on YouTube, man, it can take some force. So.
Did I let him play again?
No. Not for a while. No,
Just
we
making
didn't.
sure.
No, we didn't play along for a long time. That was a pretty rough deal. Okay, so there's our shoulder. So let me just kind of say it this way. When you see those, there's a lot that went on right there though, because you have the muscle definitely that you can see. But what's going on the inside? You think of labrum, you think of rotator cuff, you think of, a lot of the ligament structure around there, stretched, torn, all the above, right? And then you think, okay, is there a big old bony lesion now, a Hill-Sachs lesion? Yeah, probably so. So it's pretty painful. So here's what you could expect. In the max protective phase on page 579, you're going to expect that we're going to restrict their activity for 6 to 8 weeks. Now, I don't need you to be like on top of that, all right? I don't need you to know that date. I'm not going to ask you that. But you can expect that it's going to be a while because there was a lot of tissue damage. However, take a look down here. It also says that if a sling is used, for the most part, we will put these people in a sling. Because the reality is if they extend that elbow, it's going to pull tight on that biceps, and that's going to cause pain. But also, this motion right here for the first 3 or 4 days is not going to work. And so think about this: I'm walking, I'm flexing and extending my shoulder. They don't want that to happen. They really want this motion locked down for a few days. Now that may be 3 or 4 days, that may be a week. It really depends on what the orthopedic doctors say at that point. But it says during the first week they may be continually immobilized because of pain and muscle guarding. It talks about the older, less active patient may require immobilization for only 2 weeks. And then the position of dislocation must be avoided when exercising. All right, so what does that mean? That means if they have an anterior dislocation, you don't want them to externally rotate. If they have a posterior dislocation, you don't want them to internally rotate, because that's the motion of dislocation. So we all good with that part? Down at the very bottom, it talks about some precautions that I do want to address. It says, in order to not disrupt healing of the capsule and other tissues after anterior dislocation, Range of motion into external rotation is performed with the elbow at the patient's side. So anything that we do as we start, we're gonna keep them down here, not up here. Because this is, again, this is the direction of dislocation right here most of the time. Is they're abducted and externally rotated. So if we do any type of external rotation, we're gonna keep them at the side. Alright, so, back to this max protective phase, or, I'm sorry, protection phase. Basically, it says under promote tissue health, that we're gonna do some intermittent muscle setting of the rotator cuff, deltoid, and biceps brachii, but that's just about it. Even your passive range is pretty limited at that point, but some doctors will, you know, tell us we need to go ahead and do that. That usually comes in on the exercise orders as to how bad it is, but for the most part, let's just do isometrics and call it good. The other side of this, when we get to the controlled motion phase, there's a unique thing here. This is typically the phase where we will stretch tissue, right? We've established that throughout our Therex career, but I want you to really kind of look at this one thing here, and that is this. In the controlled motion phase, it says the only mobility techniques that we use are joint mobilizations. We really don't want to stretch, because here's the deal. These tissues are already stretched, so we don't want to stretch a hypermobile tissue. So we're gonna avoid stretching altogether in that phase, and we're gonna strengthen, and take a look at what it says. PWB and stability. Now what do you suppose we're talking about there? What would PWB most likely describe to you as a therapist?
Partial weight bearing.
Okay, so now go back to lab. Think about what we've done with partial weight bearing. In the control motion phase, we're gonna bring in those partial weight bearing techniques. So that could be sitting on the table, leaning into it, that's for time. Then it could be that we're bringing them into a plantigrade position. We're doing exercises in the closed kinetic chain. We're developing that neuromuscular formation again, and we're bringing in that controlled mobility. Now, that I have all of you in here at one time, let's say this. Controlled mobility, best described in your score builders book in the neuro chapter of all places, and I'm sorry, best described there as a technique that involves rotation with weight bearing, right? So rotation, humeral rotation of the axis is this right here, right? Internal, external rotation, but also we bring in the circumduction. And so that's what we want you to understand, but it happens under weight bearing. And so for controlled mobility, they have to have weight bearing component. Again, that's guarding that elbow and wrist. For your stability, isometrics will work. But then we want to get into some dynamic resistance. So let's think about it this way. How could we develop a dynamic resistance for our shoulders after they dislocate? What are some examples we might use?
Rockwood protocol.
I love it. So what was the Rockwood protocol? 5 exercises. What were they? Flexion, extension, internal rotation, abduction, and external rotation. 5 simple TheraBand exercises, right? And they're protected. We keep them at about 45 degrees and we're rolling right there. All very, very safe. It does talk about in the return to function phase, and this is not on the slide, but it does mention how we could start them into eccentrics. Also think a lot about your PNF patterns. We've kind of escaped the upper extremity without talking about PNF, but let's remember, you know, especially D1 and how we will use rotation in D1. We don't have to come all the way across if that's not permitted at that time, if that motion is not permitted. but just think about what can we do, and then think about D2, always moving into external rotation, right? Can you resist it? Yes, you can. Can you do concentric resistance and eccentric resistance and all those things? Bringing those in because it's a super functional movement. Now, if we looked at hypermobility and we looked at it from a surgical perspective, that means that this person, maybe they've had trauma. Maybe their friend let them dislocate in the gym. Maybe they did this multiple times in a sporting event. Maybe they just have multiple atraumatic dislocations, and the physician says, we're going to fix this. So here's what you need to know about that. If you look over on page 582, or actually starts on 581, it lists, beginning at Bankart repair, some of the very common ones that you need to know about. Now, Bankart is kind of the big one, and you're going to hear this terminology, and you're just going to see these patients, and they're going to come into your clinic, and they're going to have Bankart repairs. But just so your understanding is there, a Bankart repair involves an open repair of a Bankart lesion. So that's where it gets its name. The Bankart lesion is a detachment of the capsulolabral complex from the anterior rim of the glenoid. Now, let me just kind of flesh that out for you right here. In your pictures, you can see, and it's probably better up here. I don't know, how does your picture look? Are you able to see some of those words on it? Mm-hmm. It's probably pretty small. Up here, you can see where the glenoid has the labrum attached. So think about a ligament that just kind of skirts the surface of the glenoid, but binds down the humerus. And so there is a tear there because of the dislocation, and they're going to go in there and they're going to repair it. And typically what they do is they suture it down. Another very common procedure is called a capsulorrhaphy or a capsular shift. Probably more commonly a capsular shift. And that's where they take the capsule, which is a little different here. Take a look at this picture, and they cut it. Now follow this. They take a stretched out capsule. Think about it. It's been dislocated. The capsule's still intact. It's just stretched out. They cut that, and then they pull it tight. So they take that shoulder, they pull it up there tight, and then they sew it in a new tightened position. That's a capsular shift. They're shifting the location of the capsule. There's also a thermal capsulorrhaphy. Has anybody in here ever worked in produce? I really need a Dakota here. Do you notice I've asked about Dakota for this? Like, I know he works in produce, and so I'm really let down because I think Dakota could have explained this to you. If you've ever bought prepackaged produce, like it's on the little styrofoam tray, and it's got this like saran wrapping over the top of it, what they do is they wrap it, and then they put that on a heated surface, and that saran wrap kind of shrinks up, right? And I don't know, don't you bake? Am I wrong?
Sometimes, but not.
I've seen your cupcakes. They're pretty spectacular. I understand. We'll get there again. So, like, if you guys understand that heat sometimes shrink things, right? That's exactly what they do. They take heat and they put it on the capsule, and I'm not sure exactly how it works, but it sucks that dude in. But I don't think it's very successful because I think it can stretch back out pretty quick. So they really like the capsular shift more. And then the last one on there is a SLAP lesion. I need you to understand what the word SLAP is. It's an acronym, and it stands for superior labrum anterior posterior tear. The superior labrum, so the very top, and they have a tear that goes anterior and posterior. So it's basically like a tear. If you were looking at it from the side, it would be a tear that happened here in the labrum. the superior labrum, anterior foot. So good news for us, the book has basically said, here's how you're gonna treat these things. Number one is, each one will have a different immobilization time period, depending on the severity of what the doctor had to do, the surgeon, right? So that really kind of is dictated by the surgeon, and so it's physician's preference. But one thing that we can look at is on 583, that it talks about immobilization, specifically direction. It says, immobilization after surgery is determined by the direction of instability prior to surgery. So after surgical reconstruction for a anterior instability, the shoulder is immobilized in a sling or splint in adduction or varying degrees of abduction and an internal rotation. So they may be here, but they're definitely internally rotated. And there's a reason why. Because if they had an anterior dislocation where this thing was coming out this way, they want internal rotation to let this scar down shorter. And that's largely what you gotta be able to know. They're just letting that go into internal rotation so it'll scar down in a short position. Sometimes they abduct it, like especially with a slap lesion, because they want that top to be closer together so it scars better. In fact, if you run into one of these, you're going to notice that sometimes they let these people stay in the sling a long time, and they don't do a lot of therapy early because they want scarring to really take place and be the new stability component. So the duration, I'm not even going to go there. It says anywhere from 3 to 8 weeks. This is one you don't need to know, right? The doctor will say, leave them in the sling for this long. So it's physician's preference on this one. You don't have to worry about it. For the max protective phase though, it says you control the pain with a sling. You use and I'm over on page 584 now. You use cold. Lots of shoulder relaxation exercises. You know what those are? Shoulder rolls, that's a good one. Maybe some shrugs, just to relax those straps, right? Because we're doing this a lot, so these things can kind of get a little tight. So we do a lot of scapular work. And that's basically where we start. It says, put some emphasis on some spinal extension to prevent a thoracic kyphosis. You turn the page, and it says this, in precaution, initially strengthen the scapular stabilizing muscles in an open chain position. So we just talked a little bit ago about what can we do for an open kinetic chain shoulder or scapular exercise. Anybody got any recommendations on what you could do there?
So open kinetic chain?
For an open kinetic chain.
Do some punch outs?
Say what?
Some punch outs?
Now remember, they're in the max protective phase, so we're just taking them out of that sling. So let's take an eye, for example, and let's bend the elbow. And there's your open kinetic chain exercise. It's an eye. It just has a flexed elbow, right? Sometimes you're like, oh, wait, is that an eye? It looks like a row. Same difference, right? How about this one? Do a little protraction, right? Same thing. Do a little elevation, and I could load that with just a little bit of manual resistance, right? So lots of options there for my scapular open. And then it says, do some pendulums.
Where are you at in the book?
I'm on page 586.
Okay.
First column underneath precaution and restore shoulder mobility while protecting tightened or repaired tissues. And then on down from there, I'm still in the max protective phase. It says I can do multiple angle, low intensity isometric exercises as early as the first week or by 3 to 4 weeks. You just do that when the doctor says we're ready to do that. So it could happen in the first week, it could happen in 3 to 4 weeks. I know. But remember, PIMM, right? Then we move over to the moderate protective phase. I'm not gonna hit you on time because that can vary depending on when they hit it. But one of the things that we look at there is here, we're going to look at not just building strength, and you can look underneath there at all those bullets to see some thoughts on how to do that. We're also going to go and regain nearly full pain-free active range of motion. Sometimes that requires stretching. So here's your focus. They're gonna have neutral pretty good. Sometimes they'll even be a little bit of internal rotation, but they may need a little extra internal rotation. You know what normal will look like based off their other shoulder, or you just go to your AAOS, but they definitely need flexion because they haven't been doing flexion. They definitely need external rotation and they need abduction. And so that's your stretching components. So we don't do that though until the moderate protective phase.
Can you show us that next bullet under there? It says stretching in positions that do not provoke instability. Can you show us what that would look like?
Well, you're gonna go back to your first rule of if they had an anterior instability, you're not gonna take them here and do that. If they had a posterior instability, you're not gonna take them here and do that. And that's more of a safety issue in the textbook. The doctor is gonna tell you when the time is right, start stretching. If that's in the moderate protective phase, or maybe even a little further down, I doubt it, probably in the moderate protective phase, they're probably still gonna say, hey look, they're stuck right here. If that's their external range of motion, external rotation, range of motion, you're gonna wanna add to that, which is gonna require some stretching, right? So you will do it then. They're basically just saying, look, for all safety measures, if they had an anterior dislocation, don't externally rotate it because that's the motion that caused their anterior dislocation. And that's really what the book is trying to do right there, is to lay that foundation out for you. I'm not saying this is not on your test for me, but I can almost imagine a licensure exam test question that would say something like, your patient had a anterior dislocation, whether they had surgery or not, what position would be the greatest risk or would have the greatest precaution for the PTA to not put that patient back into? And honestly, I would lean more into thinking the anterior dislocation because they're the most common. So you would want to avoid external rotation, specifically an abducted external rotation. All right? So think about this. Here it is. That's how you dislocate anteriorly. Everybody see it? Kendall had his arm right here. He was trying to lift. The dumbbell went like that. And in my mind, I did this. But I don't really think that happened.
What did you do, like, while your parents just sat there and slept? You know what I mean?
Watched Good Morning America. Ate some Cheerios.
Just waiting.
Made a protein shake.
Still gotta get that
Shape
ball
was
right.
really good. Still gotta get it.
So we may have to have coffee and cigarettes before we got it.
Kendall, is that the shoulder that you broke the class on?
Yeah, it's been a really sucky life.
Bro.
Wow.
I mean, it might as well happen to this side.
Mm-hmm.
Better one than both.
What's that?
The better one than both.
Yeah, exactly. Alright, so you guys feeling good? You might look here under precaution, the very end of that, and after anterior stabilization, do not initiate dynamic strengthening of the internal rotators from full external rotation. When strengthening the shoulder extensors, do not extend posterior to the frontal plane. And similarly, when strengthening the horizontal abductors, do not horizontally abduct posterior to the coronal plane. They're really trying to say, listen, start them in neutral. Don't start from a externally rotated place and then start internal rotation. Even though our therapist brain is like, we want to strengthen and lengthen, it's just, you're dealing with an extremely delicate tissue. Whether that was surgically repaired or not, it's super delicate. What they're just saying is, don't take them to that full end, lengthen those things out, and then start. Let's start from a little calmer position, because we want that to tighten down. Unlike everything else we've talked about to this point, we want this one to tighten down. We do. All right. So that kind of ends our shoulder. And that brings us into the next chapter. And before I do want to show you 592 all the way through the rest of the chapter right there has just some really wonderful demonstrations and illustrations on things to do. And so you might look through some of that and get some ideas. It talks about on 600, it has a whole page dedicated to static, closed chain, weight-bearing stabilization exercises for the scapula. And then if you turn back, you get a whole page of open chain scapular stabilization exercises. So it's all right there for you. Just choose what you like to give you some reference. But it is important that we start most of what we do in the open kinetic chain, as the shoulder and the elbow and the wrist are not ready for weight bearing in the protection phase, more closer to late protection, even in the controlled motion. Alright, so I'm going to jump into this elbow talk here. This develops on page 600. And 19, where it talks a lot about the anatomy. I do want to show you some things about the anatomy. Number one, the elbow, by virtue of the capsule, and this is kind of the first time we really addressed this, because this is really where it crops up. Was it Vanya who said something about capsular patterns? We've talked about it a little bit. And really what I want you to understand is capsular pattern is basically when the injury has occurred, they have a capsular range of motion restriction. All right, so let's make that make sense. When you have a capsule that's restricting your range of motion, you don't have a muscle and you don't have a joint limiting the range of motion. So some of the things that we'll see are specifically when the motion is restricted, it's a muscle. It's a muscle. Some things, especially post-surgically, we'll see a few things that the capsule has bound down. So think back to the shoulder. Was there a capsular pattern associated with the shoulder? Yeah, it was called adhesive capsulitis. Right, so the word capsular pattern, it just means, for some reason they've assigned the word pattern to it. It's when the capsule has restricted. And so you think about it, it's almost like a, and let me just test you on this. Abnormal, what do you think? Firm Or would you say it's
I'd say firm.
empty?
Pretty much like ligaments, right?
Yeah, and in this case, it's an abnormal firm. Empty is another word that sometimes would get thrown in there, and I don't know that you would ever find, a resource that maybe wouldn't indicate that that's possibly what it would be. Or maybe even another person in the clinic may say, no, I just think that's empty. Okay, whatever, they don't tell it. For most of the time, you're gonna find that it's just kind of an abnormal firm. So, that being said, it does have, just by nature, a lax capsule. I mean, you think about what your elbow does. It's rarely like here, you know, in this tighter capsule from extension, or a tighter capsule from flexion. It's just kind of loose by nature, right? So it's a lax capsule. Oops, I'm all wrong. Alright, we're back. So two major ligaments, radial collateral and the ulnar collateral. Radial is lateral and the medial is the ulnar. Some muscles that we want to talk about, but we're not going to spend a lot of time on. Look on page 620 and 621. You can see the list right there. I'm not going to burn you down on those, but I would like to draw your attention to just a couple, specifically what elbow extension has, not just the triceps, but that little thing called the anconeus. I would just kind of remind myself of that. Look at the supinators though. Not just the supinator muscle, but the biceps brachii and the brachioradialis, all given some love on supination. The pronators, that's great and easy for us because those are only two pronator specific muscles. And then we want to look at the relationship of the wrist, hand, and muscles to the elbow. The wrist flexor muscles, what epicondyle are the wrist flexor muscles on? Medial epicondyle. What epicondyle are the wrist extensors located on? Okay, so do me a favor. Find your lateral epicondyle real quick. Okay? It's kind of back here. A lot of times we kind of try to cheat it over here. It's kind of back here. So kind of keep that in mind. Medial, it's right here, right? So find those condyles of your humerus. That way you're really good in reference there. Some nerves that we want to just kind of run over real quick. The ulnar, the radial, and the median nerve all pass through the elbow, right? And the one that I just kind of like to think about the most is this one right here. And I forget who I guitar stringed the other day with a ulnar nerve, but you can grab and find just that cubital tunnel. Remember that medial cubital tunnel. Find that median nerve. I'm sorry, that ulnar nerve. Oh, there it is. Everybody. Oh, got me encountered. Also, the radial nerve, where it pierces the lateral muscle septum anterior to the lateral epicondyle and passes through. The median nerve, it courses the elbow region deep in the cubital fossa. So probably not somewhere we're going to grab. Alright, so let's talk about this one. Elbows dislocate too. And so there's your perfect picture right there. Anybody want to guess how the most common elbow dislocation occurs?
Foosh.
What'd you call it?
Foosh.
What's foosh?
Fall on outstretched hand.
Fall on outstretched hand can definitely do it. Bam. They hit here, and what that does is that shoves the ulna or the olecranon process out of the olecranon, right? Another thing that happens, sometimes is parents, and I'm a crappy parent, I've yet to do this, I'm not saying it won't happen to me. You grab the kid, come on, let's go, quit looking at that toy. Johnny's is thinking, oh, he knew I did this. No, I'm just kidding, I'm sorry, that was. But they grab their kid, they pull like this, and what they do is they grab a hold of the distal radius and ulna, and when they pull, they can dislocate from the electrode on there. It also can have a radial head displacement or dislocation. That's called nursemaid's elbow. And the radial head will pop out, and this kid will have elbow pain, and they can't do, supination or pronation. And that's usually when they end up in the ER, and the ER then calls Child Protective Services. So you kind of know the story. If you see those in young kids, that's probably been part of the history, just kind of a thought there. I'm not saying that anything happened like that. You don't know all the time what the story is, but that's your dislocation. Lots of things happen when the dislocation occurs. Look at all those nerves passing through there, but also look at that binding of ligaments, right? And then there's also this joint capsule. So lots of things happen. Also listed with that, things that can shut it down pretty quick are RA, juvenile RA, osteoarthritis, sprain, dislocation. Now, this would suggest that there's hypermobility afterwards, but what we're talking about is when they do it and they guard up, and so it's kind of the result afterwards of they don't use that very much because they have immobilization occurring, and so they develop some adhesions from that, which are more common than the hypermobility issues. But take a look. This is a long arm cast where it goes in. Anybody ever worn one? I had one in 6th grade. It was really fun. And that will cause some contractures and adhesions. And then one more thing that we want to kind of address, and this is a really great location for this, called myositis ossificans. So this was one of the best pictures I could find on Google for this condition. Alright, so you've heard of this before, but it was possibly termed something different. Maybe it was termed heterotopic ossification. And maybe Ms. Hobday talked about it in spinal cord injuries. Am I getting close anywhere?
We don't have no topic ossification.
Do what?
We know that word.
Okay, so you heard it referred to as myositis ossificans. Alright, so just another name for it. In fact, if you'll turn to 656, this is better. 635, sorry. This is a better spot to see it. Ectopic bone formation. And this is a great location to learn about this condition because the book does a great job right here on 636 of describing this. It basically says, listen, you can see this in 2 areas. So we'll address it again when we get to the other area. But today, you can see it in the, specifically in the elbow region along the anterior surface around the biceps or the brachialis muscle. You can also see it in the thigh, specifically in the quadricep muscle. Now, this can happen for 3 reasons. Number 1 is trauma. So think about getting punched here or receiving lots of trauma in the quad. Think about a football running back who gets hit a lot in the quad. In fact, I read somewhere where the famous running back Emmitt Smith had this condition in both of his quads. But after retirement, apparently it resolved. Another one is neurological pathology, so specifically spinal cord injury, traumatic brain injury. Your book also talks about how you could see this in the 3rd level of burns, or the 3rd classification of burns. So those are the 3 areas where you're going to see myositis ossificans or heterotopic bone development.
What was that last one you just said?
Burns?
Burns.
Yeah, it's on
Oh, burns.
burns. another statement there, passive elbow extension is more limited than flexion. Now, I really want you to kind of process this. That bone is developed probably in muscles of elbow flexion. So a lot of times people look at that picture and think about this from a licensure standpoint and say, which motion is limited? And they think, oh, well, there would be a bony infill right there. I'm certain it would be a hard infill. I couldn't force elbow flexion. But that's really not what we see. We see most of the time that they have a restriction in elbow extension because that bone won't let that muscle lengthen out. So I have a precaution for you. It's not in the book. It's a wonderful place to share this. Many times we see things like this and we say, oh goodness, I see that I cannot, I'm coming to you, Corey. I cannot extend that. You know what? I'm a smart therapist, a good PTA. I'm going to put me some ultrasound on this right here. And we'll get that muscle to relax and then I can stretch it out. Well, here's something that maybe you caught about ultrasound, maybe you didn't. Heat is heavily contraindicated in the instance of bone or heterotopic myositis ossificans. Because if you heat that, what you do is you form more. So you cause that bony growth to occur more and more rapidly. And so you actually magnify the condition. So we don't thermally ultrasound a myositis ossificans. This is totally outside of the scope of a Therex class, I get it. But I think it's entirely too important to pass up and not talk about when we're here and you can see it. If you put ultrasound energy on that big old bony growth, you're going to make it a bigger bony growth.
What about pulse? Didn't we say something
I
about
think
pulse?
you would be fine with pulse. But my position is, I'm not even going to give it a chance. I really am not. I think Bill would probably argue and say, no, do the pulse.
I thought we had an argument about how pulse would actually help get rid of it, but
I would agree, but from my position, we're talking like maybe days, and I don't even mean like a week. I mean like literally like a few days that may help in. Because when you look at the management side of this, all you're doing is just letting them reabsorb the bone. That's how you fix this problem. So it says, under management, massage, passive stretching, and resistive exercise are contraindicated. Well, if that's the case, what can you do? Nothing. Take a look at what it says. It says the elbow should be kept at rest in a splint, and they should do active, pain-free range of motion. Nothing else. That doesn't require a PTA to supervise, really. So you have a precaution of no ultrasound that might get them a few days, but really what you need to do is just let them do their active range, reabsorb the bone, and call it good. Now, just as a side note, think about why this is such a problem with spinal cord injuries. They can't do active range probably in that area, unless their level is low enough. Like in the arm, that might be doable, but in the legs, if that happens, it's not doable. So, just some thoughts. I mean, it's a really tough condition to deal with. Any questions before I jump off that? All right, here we go, looking at some joint hypomobility specific to our elbow, and we're going to have to go backwards in the book just real quick. to page, 623. So first of all, you have an acute stage and you have a chronic stage for your joint hypermobility. That acute stage, you know what's going on right there. They're getting all the pain. And so with that, it says symptoms are acute. They have joint effusion, they have muscle guarding, they have pain, restricted elbow flexion and extension. Also pain at rest. And so I'm reading verbatim off of acute stage on page 623. And then chronic, it says this: a capsular pattern usually exists in the subacute or chronic stages of tissue healing. So what we know is that elbow flexion is more restricted than extension. Let me say that again. In the subacute phase, elbow flexion is more restricted than elbow extension. That means they can't do this right here, where they can do this right here. And that's largely because after injury, they will kind of settle into this position right here, and then they won't want to do that.
Are we talking about the monocytic?
Nope. Nope, we moved on. We're on the next slide, and we're on page 623.
This is just all type of mobility.
This is all hypermobility. Now, that's not to say you may not see extension restrictions. It's just saying that most of the time where they're going to be restricted is in flexion. And so we're painting two different pictures from the myositis ossificans to this, right? Now the protection phase on page 623, it talks about a lot of things, all the way from educating the patient, which first of all, we tell them what they should expect right there. Also reducing some of the inflammation. It really does a great job here of saying immobilization in a sling is definitely a part, but frequent periods of controlled movement with a pain-free range should be performed. So how do we do that? We use passive range. And as talked about more on page 623. So we can do passive range there. And then it also says on 623, multiple ankle muscle setting of elbow flexors, extensors, pronators, supinators, wrist flexors, and extensors in a pain-free position. So here's what that painted for us. The PIMS, again, passive range, isometric, mobilizations, and massage. All things that we can do in that first phase. Then as we skip into the second phase, it talks more about some specific things, but I want to talk about two very specifically, and that starts on page 624. Number one, manual stretching and self-stretching. So we showed you in the lab this morning how to stretch a bicep and a tricep, right? So let's talk about this. How would one best do that in the self-stretching though? What could one do to self-stretch an elbow? Now think about this just reasonably. Think about this just reasonably. Now, that's just so simple, isn't it? To get that elbow flexion. How would they get the elbow extension then?
Put it on a table.
Yeah, Aaron just did it, like, bam, right? You also have to think, like, they're stretching because they don't have the range, so it's not very hard to do. It's really not. I mean, if they're here, I'm just coming in and I'm self-stretching. They will know how to do that. That's a very simple technique to teach. Now, when you move to strengthening, over on page 625, it says, initiate active and low load resistance exercise in open and closed chain positions to develop control, muscular endurance, and strengthen the muscles of the elbow and forearm. So we want to do both. Open and closed kinetic chain. However, they may not tolerate closed kinetic chain early. It may be open first. And that goes back to their X1. Remember we talked about using open kinetic chain first, then moving into closed kinetic chain or weight bearing after they've had some time. So we just kind of play with what we have. Here's a good old picture of an elbow ORIF, open reduction internal fixation. I really don't talk too much about the surgeries on elbows, because the thing is, when you bring in an elbow surgery, you're bringing position preference on a lot of things. We're talking about something that has so much ambiguity to it, you don't really know how to predict what you're going to get. And so the position is going to dictate a lot of that. One of the things that we do kind of anticipate is there's probably some immobilization. It probably looks like a splint or a sling. If it is splinted, I do want to show you this right here. On 627, the elbow immobilization technique at the very top right-hand corner, it says, is immobilized continuously in a well-padded posterior resting splint in a position of 90 degrees. Now, try to put, I did not get a picture for you here, but try to imagine what we're looking at here. We're talking a posterior splint at 90 degrees. That means the splint comes down here and here, right? And it's usually wrapped, and then they're also going to wear a sling. But the splint is always going to be a posterior splint. And you got to kind of just think that's probably because of gravity, and that's the most efficient way to do it. I don't know that you would ever get asked that question at licensure level, but now you know a posterior splint is what they're going to wear. Some of the other unique things here is sometimes they'll do an excision of the radial head. There is an arthroplasty technique. I have never seen one. I don't even feel worthy about talking to you about it. I've never seen an elbow replacement. However, there's a really cool picture in your book that shows it. So let's do this. You have an elbow surgery, period. That's all you know. What do you anticipate your first day of therapy looking like? Probably going to involve some shoulder, wrist, hand stuff. So think about this. What would you first start with? Think about the scapula, doing all those scapular motions, right? Maybe you do some internal, external rotation, unloaded, right? Now think about the wrist. I probably could load the wrist, do a little TheraBand, wrist extension, TheraBand, wrist flexion. Talk to me about some finger exercises that I might want to do. I know you already know a few. Give me something. Give me something.
Ball squeezes.
Opposition, what you got?
Ball squeezes.
Ball squeezes. Yeah, I know what you're talking about.
I'll take quick.
Another one that I like is the clothespins. Taking and just clipping them, right? They may not be able to move very much here, but they may have abduction, adduction. That would be a very good thing, right? So it really, it just depends on what cards you're dealt, you know, is what you can do there. And then you just have to follow out with what they say. So if they have passive, if they get isometrics, and then in what phases they can do that in. That's largely taken care of though by you and the communication that you and the PT and the doctor will do. All right, so let's talk about this one. This is the money maker as far as I'm concerned for the elbow. And that is the overuse symptoms, specifically lateral and medial epicondylitis. So I want you to just process that word. epicondylitis. It indicates that there's inflammation at the condyle. That's fine. What muscles originate from the lateral epicondyle? The wrist extensors. And what muscles originate from the medial epicondyle? Wrist flexors. So find yourself on a very, what I would call lucrative page in the book, 637. I'm sorry, let's go 638, 639. The thing is, when we treat epicondylitis, where do you suppose it hurts? Let's just all say we're treating lateral epicondylitis. Everybody grab that lateral epicondyle again. Mine's chronically sore. Right there. Right there. So now you got to convince your patient that they need to wear one of these things that are pictured here in the slide. And you know what they say? Listen, dummy, it's not my wrist that's hurt. It's my elbow. What's your response?
Those muscles come from right there.
They come from right there.
Well, I explained to them.
Well, do it. Come on, I'm your patient. Give it to me, baby. I love it. Come on.
Well, we want to keep your wrist from going into flexion when you do epicondylitis, because those muscles are inflamed. So,
Yeah, he's going to work that out a little bit. He's going to work on his description. You have to convince them that this motion right here has got to be shut down. Now, take a look. What is this syndrome? It's overuse syndrome. That means that they've been doing some type of wrist extension or wrist flexion that's caused this. Now, here's a really good way of remembering this. Actually, I don't care for this at all. I think it's really confusing, but this is what they've done. They call these things tennis elbow and golfer's elbow, right? So here you go. For the tennis elbow, it comes from the backhand because there's a lot of extension in the wrist. With golfer's elbow, it comes from right there because there's a lot of flexion in the wrist. I really think that's largely confusing, but that's something else you may hear. With lateral epicondylitis, this is the one that's probably most common. My first go with lateral epicondylitis didn't happen until just a few years ago, and I spent probably, all said and done, about 3 hours running a leaf blower on a trail just after the leaves had fell, and I was blowing off the trail for mountain biking. And it took me about 3 hours. I had this hand, I was carrying a gas jug, this hand, I was carrying a leaf blower, and I just did this. Right here. And I don't know how many miles of trail I blew off, but I blew off a lot of trail. And when the gas would run out, I'd fill it back up, and here I'd go again. And the next morning I woke up, and I was like, oh heaven, this is bad. It was bad, like bad, right? And so like now, this thing is, it's tender to touch still today. So what we know though is we gotta put these people, and we gotta limit the pain-provoking position. So your job will be to say, don't move your wrist. Don't move your wrist. This is exactly what we won't let you do, is move your wrist. And they'll say, but it's my elbow that hurts. And you have to convey to them, we know it's your elbow that hurts, but it's not the elbow motion that's gonna hurt you. All right, so that's step one. Gotta immobilize. Number two, you gotta stretch it. All right, so everybody get their their wrist extensor muscles and stretch. Go. Get your wrist extensor muscles and stretch. Get your wrist extensor muscles and stretch. Let me say it one more time. Get your wrist extensor muscles and stretch. Here we go. One last time. Get your wrist extensor muscles and stretch. Donisa's she's questioning. She doesn't know if she's right. She's thinking about it. Are you getting your wrist extensor muscles stretched? I'm looking. I'm starting to grade. Oh my, who's going to get a good grade? Let's see if we did this right. If you took your wrist and you put it into flexion, you did the right thing because you put it into motion that was opposite the direction of action, right? So give yourself a pat on the back. Right? Good job. You couldn't do that if you were wearing a wrist mobilizer though. It'd be like this. So that's stretch. Now, how long should one stretch? Let's go back to Derek's one. What do you think a good duration of stretch should be?
30 seconds.
I'd say spot on for academics. I'd say for this patient, they need to learn to do this and hold this for probably 3 minutes. Now wait a second, let's go back to the stretch chapter. Low load, long duration. If it's 3 minutes, listen, this right here, they don't want to get carpal tunnel though, right? So it's low load. So be very gentle in the way you teach that. But honestly, if they're sore, it's not going to take much. And they're going to go, oh, there it is right there, right? So they wear the brace full time. They come out of it because they can't stretch wearing it, right? And then the next thing is this. Eccentric is king. Take a look on page 639. It talks about a lot of the things that we were talking about before. But take a look under dynamic resistance exercise. Progress to dynamic exercises against manual or elastic resistance through pain-free range of motion. Initially use low intensity resistance with multiple reps for muscle endurance. That makes perfect sense to us. We're like, yep, I'm right on that, Kendall. Good go. Then it says, progress to more intense resistance to strengthen the muscles in preparation for functional demands. Eccentric training. The bullet underneath there does not make any subtle suggestion here. You're using eccentrics. Incorporated progression of eccentric contractions of the involved musculotendinous unit. First, within a comfortable wrist range of motion against a low intensity load at a slow speed. So, first, at a low load, slow speed. Jump now for me in the text, down to focus on evidence. It says, eccentric training often is recommended in the literature and implemented in the clinical setting to reduce pain associated with epicondylitis of the elbow. So we stretch them, and then we got to learn our eccentric resistance. Now, let's talk about how to do that. When you are going to strengthen this patient, you've got to have them calm and easy. So jump with your peer or your partner from lab, and let's try doing just some really slow, low resistance eccentric exercises, starting with our wrist eccentric. Jump in there.
I'm already done. So that's the 5 minutes. Or resist me. Whatever.
Yeah, resist me, but let me win. Fight me.
Fight
Get knocked out.
I'm not even fighting. What am I doing? So that's.
Everybody just keep moving.
So then.
Okay, I'm sorry. Okay. This is the selection.
What would you do with it? Supine or post?
So he said,
So I would take you out
stretching.
This is this, the extensors.
Extensors. You just do supination.
I think the fingers are like pointing down when you're stretching, but then it's strengthening so there is, put it in it, try and take it out for eccentric.
Yes.
But if they were stringing it themselves, or like just isometric would be resistance.
Yes.
So that's a lot to remember.
Yeah. I need to get that down.
Yeah. So no, yeah. I don't really want to do this meeting more new ones, but flexors. That's what we're figuring out. Because that's what we were doing.
So this is eccentric.
Yeah, right. I think because you're
All right, let's progress. In the book it says, progress to faster speeds before increasing the resistance. Let me say it again, progress to faster speeds before you increase resistance. So, just on yourself, use the same resistance, now go faster, faster, faster. So you got to have a lot of control with your patient, indicating to them what they're going to need to do. Turn the page real quick for me. I do want you to see on page 641 other ways to stretch the biceps using an ankle weight and basically stabilizing the elbow on the table, using a table and standing, and then showing you the picture of stretching the triceps. Please don't forget supination and pronation. They kind of will get that a lot of times. And then our last slide, and this is just more of an FYI, you will not find this in your text, but I do need to share with you, there are some unique wrist fractures that you're going to hear about. Chances are you've probably heard about these before, but let's just make this very clear. The leading wrist fracture in the forearm. Let me say that again. The leading wrist fracture in the forearm is known as the Colles fracture. The Colles fracture, as denoted in the picture, is a posterior displacement of the radial head after fracture. Is a posterior displacement of the radial head after fracture. It is the most common fracture in the forearm. Now, this is a dangerous place. It's like hemiplegia and hemisphere. It's like cough and choke. You hear forearm, and then you see the word wrist. The most common wrist fracture down here at the bottom of the skateboard. The most common wrist fracture. You got a wrist and you got a forearm. The wrist indicates the carpal bones. The forearm indicates the radius and the ulna.
Kendall, whenever you say posterior on the Colles, we're talking like in anatomical position and
Yes.
then posterior.
Yeah, it gets a dorsal displacement.
Okay.
So actually, when you see one, they kind of have this look right here. It's called the dinner fork deformity. And this bone will be popped up right here. Not that you guys see those acutely, but they still expect the PTA to know these things. I just need you to trust me on this one. So there's one more, and that's known as a Smith's fracture. And that is the opposite of a Colles. It's where the radial head displaces in a volar or anterior position. So they get this, where that direction of displacement occurs. And so I hope you can see them well on the pictures in the slides. I try to get those on there for you really well. One other key thing that I do want to demonstrate for you here, that scaphoid fracture is kind of a nasty little deal. All of these come from FOOSH. That's an acronym for fall on outstretched hand. When the scaphoid is fractured, it can undergo such a unique fracture that it does not get a blood supply into the fractured area, and therefore it doesn't heal. And you've probably heard of this, but we'll go ahead and reiterate it. Non-union, and then another condition known as avascular necrosis, AVN. And so those are just some of the technical things about those fractures that we want to warn you about for licensure level prep.
So the non-union just means blood supply?
It will not, yeah, most fractures, when they occur, they have a good enough blood supply that the bone formation occurs. It doesn't happen. So it's a non-union from avascular necrosis. Or then you get an avascular necrosis. Alright, you good? I'll shoot you guys out a upper extremity to 87.